Welcome to Medical Matters Weekly with Dr. Trey Dobson, presented by Southwestern Vermont Health Care and Catamount Access Television.
Welcome, everyone. Today is May 4th, 2022, almost Mother's Day in a few days. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. My guest today, and for full disclosure, is one of my colleagues. He's a medical director and chair of the Department of Emergency Medicine at Southwestern Vermont Medical Center. He is a Dartmouth Health physician, and he works here in Binghampton. Adam Cohen, thank you for coming on the show today.
Thanks, Trey. It's such a pleasure to be here talking to you.
Yeah, actually, our offices are very close, so we could almost be doing this in the same office, but we're doing them in different offices. A little bit about Adam. He has his medical degree from the State University of New York Medical Center in Brooklyn. He's done many other things. He completed his residency training in combined internal medicine and emergency medicine at the Allegheny General Hospital in Pennsylvania. He also has a bachelor's in psychobiology. Is that right, Adam?
That's right.
I'll ask you exactly what that means in a little bit. And he is certified by the American Board of Emergency Medicine. So before we get into some of that education, Adam, just tell us a little bit about where you grew up.
Well, I like to say I was born at a very young age in a strange and distant land. That is Queens, New York. Quite strange. And I actually grew up and spent most of my earlier life and education in the New York City area. I went to high school in the Bronx at the Bronx High School of Science, which is fairly well known in certain science circles. I went to medical school in Brooklyn and then did the rest of my training in Pittsburgh. And I moved out here in 2004 after I finished my residency and was a simple and humble ER doctor up until taking the reins from you in 2012. Right now, I'm the chairman of emergency medicine. I direct this department as well as the urgent care, express care on campus. And it's been great. I think right now I'm technically the first or second longest tenured emergency department chairman in the state. Wow,
that's fantastic. And we have about, 15 or a little bit less emergency departments in the state. And I know you're close with all of the directors who get together regularly. Tell me a little bit about what a degree in psychobiology means.
Oh boy, I got to go way back. So I guess when I started college, I wasn't really determined to go into medicine. I thought I might be better off in psychology, but I had a strong interest in biochemistry and physiology, and psychobiology tends to blend those two things. So it focuses on both the neurobiology and the psychology and behavioral aspects of that area in healthcare. And I actually remain quite interested and abreast of the literature in that today. I spend a lot of time researching, what the neurobiology is behind certain aspects of behavior, especially when it comes to things like addiction and behavioral problems.
That's excellent. I was going to ask you how that affects your practice today. Do you think it gives you a little bit, I'm not going to say more insight, but a different insight than maybe someone who doesn't have that background?
Oh God, it totally does. And it totally affects my understanding of certain illnesses, and it totally affects the way that I handle myself in my own life and recognize things that we're exposed to that are really incongruous with the environment that we are supposed to be in. So things that are extremely highly rewarding and how those affect the various brain pathways that influence our behavior. I think having an understanding of that really helps you to recognize why you do certain things, why you behave certain ways that otherwise seem impossible to understand.
And when you're in residency, you did something that's pretty rare. You did almost 2 residencies sort of combined into one. So tell us a little bit about that.
Well, so one of the things I realized when I was in medical school was that you had a couple of different options when it came to picking the next phase of your medical training, which is residency. And a lot of those options were highly reductionist, meaning that you could choose to pick a specialty where you would essentially sacrifice most of your medical training and your ability to understand the whole broad spectrum of the human condition and health, and rather focus on a very narrow area. And I just knew that that was something I didn't want to do. I wanted to stay as broad and know as much about all of the human condition and medicine as possible. And that led me to this residency program where I was able to dual board in two of the most general areas there are in medicine, which is emergency medicine and internal medicine. And I have maintained my board certification in both since then, even though I practice primarily emergency medicine at this point. I'm also in the process right now of training in an even less reductionist and broader field, which is known as functional medicine.
All right, you open it up. Let me hear a little bit about functional medicine.
So yeah, it's, I struggle trying to figure out how to describe functional medicine to people. I think that functional medicine at its core recognizes that there's a fundamental mismatch between the environment that we were evolved to exist in and our current environment. So we're a finely tuned organism to be perfectly adapted to an environment that existed 15,000 years ago and bears little resemblance to the environment that we live in today. And the changes in the environment are escalating as time goes on. Our current environment bears little resemblance to what it was 200 years ago. And that then influences a lot of our genetics through a process called hormesis, which basically refers to how our environment affects our genome and the output of our genetic makeup, and that this is the underpinning of a lot of modern chronic illnesses. And so functional medicine tries to, address those fundamental causes of chronic illness in that frame.
And do you see that as a, you said you're training in it now, do you see that as a pathway for your future emergency medicine practice, or something maybe even in adjunct to your emergency medicine?
Both. I think it would be viewed as very difficult to apply functional medicine in the emergency department just because it's a very time-intensive type of practice. But I can certainly see the application of it in the emergency department. And I know of other emergency medicine doctors that are certifying in this as well. And when we discuss that, we absolutely find ways to help counsel patients around chronic diseases, which of course is not something that's ordinarily endeavored in an emergency department. We also tend to try and be reductionist and sort of reduce patients to the presenting problem. So in contrast to that, I do certainly apply some functional medicine to my patients here when I think it's applicable and they'll be receptive to it. But also I think it's a service that is lacking in the community, and that someday down the road I hope to provide.
That's fantastic. For the audience here, I just want to back up a little bit, and we're going to go into some aspects of emergency medicine and our emergency department here at SVMC, as well as just emergency department design in general. But I just want to back up and again go back to Dr. Cohen's residency. So we actually did, in a sense, two residencies. One where you called internal medicine, where you really look at chronic disease and the treatment of that disease, whether they're hospitalized or in an outpatient setting, called internal medicine. And then emergency medicine as well. That's too much information to put in one residency. Emergency medicine really focuses on acute, somewhat life-threatening or certainly acute situations in an emergency department, which is a whole residency itself. Adam, I'm going to ask the obvious question, though. When you came out, you actually had the opportunity there for, unlike myself, who could only go into emergency medicine because that was my residency, to do either both, which is very difficult, or one or the other. What made you choose to do emergency medicine?
Oh, good one. Well, so my plan was to do both. It's just that when I started here, the need was the greatest in the emergency department. And so I took the position full-time in emergency medicine, and it just kind of took over from there. It's kind of difficult to stay current in both at a high level, but I also, did kind of like the lifestyle and the workflow a little bit better, but I also still have tremendous love for inpatient internal medicine. I hope someday to get back to that.
Oh, that'd be great. If we could clone you, we'd put you in multiple different parts of the hospital. So back up to when you made this decision to come to Vermont, what attracted you to Vermont out of curiosity?
Well, to be perfectly honest, it had nothing to do with the exact geography or the location. We were scanning a wide area through the northern tier of New York and into New England, just because we had to narrow our search somehow. But other than that, I really didn't know what I was looking for. And so I did a ridiculous number of interviews. I probably went on 12 or 14 different interviews in the most unconventional way, which is that we didn't call anyone, we didn't set up any interviews, we just got in the car and took out a map, circled the hospitals, and just decided to go on a week-long trip and drive around and talk to people. And
that is awesome.
Yeah, and so I kind of drove through and just walked into hospitals and talked to people in emergency departments. And when I came through here, I spoke to the then director, who's still working here, Dr. Yucht, and there were no positions. And I came very close to accepting a position in southern New Hampshire when at the very last minute, probably within a few days of me making that decision, I got a call from Jeff and he said, "Hey, we have a position." And the reason I think that with that process I was attracted to this place was I was really way more interested in having a reasonable and supportive work environment. I really wanted career longevity, and I wanted the ability to practice medicine with some autonomy over virtually everything else. And this was the place where I felt like I would have the opportunity to do that. And fortunately, in large part due to folks like yourself, the institution has really maintained that culture.
We had a lot of foresight to know that coming out of residency, because most individuals don't have that insight, and then it takes a couple of years before they realize, wait a minute, this is not exactly what I was looking for. So that's fantastic. And that did happen to me as well, because it's a second career for me. So I had already gone through some of that. What do you do? We're going to go back to medicine, but real quick, what do you do outside of medicine? What do you do for fun?
Oh man. So yeah, I do some crazy stuff. So I've got a good friend and we sauna a couple of times a week, which means that we basically slow cook ourselves at 200 degrees. And it's incredibly fun and it feels great. And the crazier part of it is that we then go and do ice showers and back and forth between that and the sauna. That's kind of fun, but I realize that also makes me sound rather crazy. There's also incredible health benefits to doing those things that are well researched, but we won't get into. If I had to say how I spend most of my free time trying to enjoy myself, it's reading. Some fiction, but mostly I'm still tremendously interested in the scientific works that are out there. And there's just so much fascinating stuff around. I keep abreast of astronomy and particle physics, quantum mechanics, and lots of psychology reading. I'm really into cooking also. I've gotten into that lately. Probably the thing that would be the most surprising, I suppose, to people, and I might stigmatize myself a little bit by saying this, but I have up until fairly recently competed at reasonably high levels in esports, including going through some professional coaching programs and competing typically with people that are much, much younger.
Wow. In what kind of sports? Say it again.
Esports. That means online competitive games that resemble sports, team-based games.
Wow, so we've known each other for 16 years or something, very close, and I didn't even know that about you. That's why I love this show and interviewing people. But that is really interesting. So when you do this, you're doing this all remotely, I imagine. You're not going to events.
That's right. Yeah, no, there are events, and it's incredible how big of a thing this is becoming. They will fill entire stadiums for some of these events, but I certainly don't compete at that level. I'm nowhere near professional, but yeah, I mean, it's incredibly fun, but I feel like it's also a really good way to just train your brain and keep your brain young and force yourself to learn very sort of challenging mechanical tasks that otherwise you wouldn't really have any way to do.
Well, you have a unique approach to health overall, much more than we're even going to have time to go into on this show, because I actually know this from knowing you so well over the past many years. I mean, you're almost an enthusiast in all aspects of health, whether that's medicine, whether that is mental, and then in the situation you're talking about here, which is even a different approach. So that's so interesting. Are you going to go into coaching at some point where you're going to be almost a full-time health coach?
Yeah. I don't think that's going to be the route. I really just do it. Some of these problems are just so big. They're almost societal. They would have to be tackled on a societal basis. Things that really involve more than our entire healthcare system, but like the food supply and those sort of things that it's really almost impossible to contemplate addressing those kind of problems on that scale. So I do really enjoy just reducing it to a single person at a time, and I coach people pro bono on the side, for metabolic health and weight loss and various things like that.
That's great. All right, let's shift gears a bit in our remaining time and talk a little bit about locally here, emergency medicine, what's going on at the hospital in regards to redesign of our emergency department, as well as just continued work in our express care. Let's go back to the fact that you are the medical director of emergency medicine, or the emergency department, and the chair of emergency medicine at SVMC. What does that mean? What's your day-to-day like when you're not seeing patients?
Yeah, well, so half of my time I am actually still a practicing clinical emergency medicine doctor. So, well, more than half the time probably. You'll see me out on the floor working a shift and seeing patients. The other half of my time is spent engaged mainly in ensuring the quality of the care that we deliver. Some of that is pretty boring stuff, like reviewing lots of cases, making schedules, interviewing new staff, administrative stuff. I also collaborate with all of the departments across the system, because the emergency department interacts with all of those departments, as well as other folks at our larger partners like Albany Med and St. Peter's and Dartmouth. Aside from that, I try to set aside some time. There's always a continuous flow of people coming into this office with various issues that they need to have addressed. That takes up a fair bit of time, as you know. But I try to always set aside some time just for thinking as well, where I just put aside all of the tasks and just allow myself to think freely about, what can be done innovatively to improve the work in the emergency department and the care of patients. And this has led to a number of innovations that we've accomplished here. At last count, we've completed over 50 quality improvement projects in the last 10 years, which is a fair number for a non-academic hospital, because it's really just myself and a small team, working on those. So some of those things have been
Oh,
pretty helpful for the community. I can list a few if you like.
Sure.
So yeah, we were the first hospital in the state to have a dedicated behavioral health unit in the emergency department. And so prior to that would have been unthinkable. But we saw that we were starting to board mental health patients longer in the emergency department, and they were mixed in with the rest of the patients, which was really not good for them, because the emergency department is a very chaotic environment. So we developed a separate small unit in the emergency department where we could provide the best possible treatment and a safe environment for them while they're boarding here and waiting for inpatient treatment. We were the first hospital in the state to have a comprehensive set of guidelines on opiate prescribing before other institutions and regulations started to push those out. That drastically reduced the amount of opiates that we were prescribing from our emergency department. And just to put a number out there, the starting number was somewhere around 15% of patients coming to the ER were leaving with an opiate prescription. And more recently, we're down to roughly 1 to 2%. It's hard to know exactly what the right number is, but it seems like that's an appropriate prescribing number for people coming to an emergency department who might have painful injuries. I won't go through all of them. We do a lot of telemedicine in the ER, as most people who know our institution are well aware. But we also were the second emergency department in the state to start treating opiate use disorder in the emergency department by starting them on medication treatment for that and rapidly referring them to outpatient treatment programs. So prior to that, it was pretty unthinkable in most places that you would actually train people and start initiating opiate abuse treatment in an emergency department. It just didn't seem like something that would be compatible with a typical emergency department. But it was clearly a need in the community. It wasn't getting satisfied in other places. And so we became the gateway for that for many in the community.
And I'll let the audience know Dr. Cohen's actually underselling some of this. He and his team actually led these initiatives, either led them in the state or others in the state followed, and really set a bar. And of course, it's very collegial with other hospitals, and that's how we are in Vermont to make sure we're taking care of all Vermonters. But I do want to say, Adam, because I haven't said enough, thank you for everything you have done and continue to do.
Thank you.
Now, tell us a little bit about, do we really need a new emergency department, and what are we going to get out of this for the community?
Well, I kind of, the impetus to build a new emergency department, really, I feel like it came from outside of the emergency department. I think we all come in and do our jobs. I think of our current emergency department as the little engine that could. It's small, the design is outdated, it's difficult to navigate, but it'll just keep pulling the heavy load uphill and it gets the job done. But it's just far from ideal. And there are certainly things that make work difficult here and make things less comfortable for patients. The rooms are really small and cramped and difficult to get equipment into. I like to say that every patient, when I walk through the door, it's an 8-step process before I can even say hi. You've got to open the door and move stuff out of the way and rearrange the room and, move belongings and stuff like that. Of course, now with COVID, it's a 12-step process because you have to do PPE first. So fortunately, the new design is going to double the size of the space overall, double each of the sizes of the rooms. Hopefully, we're going to Marie Kondo the department and have things organized better and have a place for everything. Communication is difficult in the current department because the staff tends to be very spread out. So the providers are segregated somewhat from the nursing staff, which makes communication difficult. And so strong consideration was given to that during the design of the department to try and get people working closer together. There's definitely privacy and comfort issues in the current department. We still have spaces that are open to the whole department and rooms that are separated by curtains, which is really substandard in the current time. So in the new department, we should be able to go to all single private rooms. And every room will be,
which is fantastic.
The whole department will be negative pressure, of course, thanks to COVID. And all of the rooms are going to be wired for telemedicine. So we should be able to offer the highest level of specialty services that we may not even have available here on site to ER patients.
Which is a huge gain. Like you said, there is certainly gain to staff, but it's to the community and to the person who's a patient, which, by the way, is not only community, it's also our own staff and ourselves when we utilize the emergency department. You mentioned privacy. That's a big gain in this new system. You alluded to infection control, which is a big gain. What about efficiencies and wait times? We actually have pretty good wait times here at SVMC, although that doesn't matter to the person who's in the waiting room for 2 hours in pain. Do you think this new design is going to improve efficiencies for wait times?
Well, we certainly did pay attention to workflows as we were going through the design, and there's actually a really large body of research done on that subject, specifically designing emergency departments and looking at workflows and addressing bottlenecks and things like that. We were constrained to some extent because we're not building a new department. We're really renovating half of a department and building half of a new department. So we were somewhat constrained, and so it's not perhaps as perfect as I would like it to be in that regard. But we certainly did pay attention to that. I think just co-locating the physicians and nurses will be tremendous in terms of improving the efficiencies of the department. We also, I forgot to mention, we're also going to have a fast track area that will be staffed by a PA or an NP, an associate provider. That includes what we call vertical rooms. They don't necessarily have a bed and they're a little smaller, but they're for the quick complaints that hopefully we can move through the department faster to keep people out of the waiting room. We didn't really talk about safety, and the department is also heavily, there was heavy consideration given to the safety of the department and how to keep staff and patients safe, and the security of the department, since that's foremost on a lot of people's minds these days. And then finally, although I'm getting a little further off topic here, part of the design includes a whole new behavioral health area, which is really going to be state of the art and greatly expand our current capacity to better take care of patients with mental illness.
That's fantastic. And what we also didn't mention is, along with these renovations in the emergency department, you oversee a completely separate area, express care, which somewhat recently, over the last year, underwent major revisions, actually a relocation, and has been a tremendous benefit to the community and getting people in who don't have medical needs that require an emergency department visit, but certainly have medical needs that require a visit today. And if they cannot get in to see their doctor or provider, how is express care going these days?
Well, I think express care has been there must have just been a huge unmet need in the community, because it's just growing at a remarkable pace. When express care started, I believe it was maybe 6 years ago, the volume, the number of patients coming through that practice every year was about 4,000 maybe. It was designed really more as a primary care overflow with more primary care workflows in mind. But the patient volume in there rapidly outgrew the space and the processes. And I think, don't hold me to the exact numbers, but I think we're on track for roughly 18 to 20,000 visits this year, which is remarkable for a practice that's open 10 hours a day. So there is significant crosstalk between express care and the emergency department. A certain percentage of patients that show up at express care do need to come to the emergency department. And so to address all of those issues, we designed a new state-of-the-art urgent care facility right next to the ER. And after the construction is completed here with the ER, they're going to be literally within arm's reach of each other and connected by a corridor, so that communication between the two departments will be much easier, and patient movement will be easier as well.
And Dr. Cohen has overseen having staff trained in both locations, so they improve that familiarity, standards of care, and it's only going to get better over the next 2 years with the new facility. And I love your analogy. It's the people are the same, the people are strong. That's one of the reasons I'm here, and it sounds like one of the reasons you're here. And the facility, we've just gotten by, but now this will be a tremendous help. As we close, just tell us two things. What are you looking forward to personally, and what are you looking forward to professionally over the next year or two?
Well, I think I can speak on behalf of the department. Everyone's really looking forward to this construction being over. I think we're all challenged with all of the construction going on around here. Personally, I'm really looking forward to learning my new field of medicine and completing that training, and potentially being able to offer that expertise to the community down the road. In general, I'm really fascinated by some of the accelerating advances in medicine and how those are going to impact our ability to take care of patients. Just a couple of those things, like for instance, CRISPR technology, which seems like it's already being used to cure previously incurable genetic disorders. Really amazing advances in stem cell research, which fortunately no longer requires fetal material. And we can create pluripotent stem cells now from virtually any cell lineage. And so that research is now accelerating. And then I'm personally very interested in working with at least one company in machine learning approaches to laboratory diagnostics and diagnosis. And we even just talked to a company this morning, myself and my nursing director, Jill Maynard, about a company that is working on a product that we might participate in research on that is using machine learning to monitor patients in the waiting room using little portable devices, monitor devices that they stick to their chest to monitor for signs of deterioration for people who are in the waiting room. Those are the sort of things that I get excited about. It's the new and unique and innovative things in medicine that we'll see coming to fruition over the next few years.
Yeah, that's great. And what Dr. Cohen is not saying is he's actually already bringing some of those into the department actually this year, which is fantastic, and more to come on announcing some of those. Well, I'd like to just thank everyone for joining us today on Medical Matters Weekly, and especially I'd like to thank Dr. Cohen for being here today.
Thanks, Trey. It was great.
I'll also say thanks to Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Health Care, and Ashley Jowett from Southwestern Vermont Health Care. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we will see you next week.